alcohol use disorder. And the 10-year survey which has been carried out in 2001 to 2011, this was seen that approximately 0.08 to 0.09 admissions are there because of alcoholic hepatitis. In the US, Ali et al. Has also reported that the total hospitalization rate is rising. Same trend what is also seen in our country also, that we are seeing not only the alcohol use disorder is rising, the incidence and the prevalence of alcohol-related liver disease in terms of alcoholic cirrhosis, alcoholic severe hepatitis, as well as fatty liver disease is rising not only because of increasing burden of the obesity, but also alcohol use. So one of the study has shown that in 1980s, when meteorological study was done, the commonest reason of cirrhosis was found to be alcohol. Of course, nowadays we are seeing more of non-alcoholic fatty liver disease in comparison to alcohol-related liver disease. So I'll start with a case scenario. So a case with 48-year-old male with no comorbidity, ongoing alcohol intake, and he presented to us with jaundice, ascites, and he was abstinent only for 15 days. On further assessment, he was found to have a bilirubin of 24 with AST of 120 international unit per liter and AST-ALT ratio of 1.5 with Madry's discriminant fraction was 56. I'll be giving detail of this in later half, and HE of grade 2. So this is what we see in routine clinical practice. So important part in any alcoholic or any patient presenting with jaundice to know the etiology and its management. So as per guidelines, the alcoholic hepatitis has been defined as rapid development or worsening of jaundice and alcohol-related or liver-related complication with bilirubin more than 3 mg per deciliter, rising ALT and AST up to 400 with AST-ALT ratio more than 1.5 and heavy alcohol use till 8 weeks before the onset of symptoms with exclusion of other liver disease. So this patient fits well into alcoholic hepatitis. So should we start the treatment with this defined definition or should we wait? Or should we exclude with the help of a biopsy? So how to manage this? First is the definition, as I said, the definite alcoholic hepatitis where histological confirmation is must. The other where we define is probable alcoholic hepatitis where we have defined based on clinical background. And the possible is just with clinical background and other confounding factor may be there. So we have to define whether this is a definite alcoholic hepatitis or a probable alcoholic hepatitis. As I said, that liver biopsy is must in all patients with alcoholic hepatitis, otherwise it is being considered as a possible alcoholic hepatitis. In certain scenarios, we go for liver biopsy, and in clinical practice, of course, this is not uncommon to go based on clinical background with the amount of alcohol consumption and the biochemical profile of the patient. However, in patients who have got atypical presentation or who have got AST-ALT in thousands, and when we are doubtful about the alcohol intake or we've found confounding toxic agents or other agents, then there is a role of liver biopsy. Otherwise, in clinical practice, most of us tend to avoid liver biopsy because most of these patients with severe alcoholic hepatitis are quite toxic and they carry coagulopathy, which demands either transjugular liver biopsy or other alternative methods. What actually we see in liver biopsy? The classical picture of alcoholic hepatitis, we see the lobular inflammation as seen this and the ballooning of the hepatocytes together with the neutrophilic infiltration. So cholestasis with biliary canaliculi and hepatocyte plugging and chicken wort or pericellular fibrosis are indicative of advanced alcohol-related liver disease. Going this bit words about the pathogenesis of alcohol-induced liver injury. As all of us know that The major pathway involved in alcohol metabolism is that when we consume alcohol, the gastric alcohol dehydrogenase converted to acetaldehyde, and then this acetaldehyde is converted into the acetate with the help of acetyl dehydrogenase. The other two pathways are paroxysmal pathway and the major inducible pathway, which are activated when we consume toxic doses of the alcohol. So this is a photograph, the same thing which has been shown earlier. The major pathway is acetaldehyde pathway, and the other two pathways are accessory, and they are being activated either by inducing pathway or by toxic doses of the alcohol. So the spectrum for liver disease, what we see in routine practice is good number of patients, almost 85 to 90%, consuming alcohol on day-to-day basis. They have alcoholic steatosis, and about 20 to 40% of this group of patients, those who have got fatty liver disease, they tend to have inflammation, which is indirectly reflected with raised enzymes, or in biopsy we can see that they have got classical pictures of the alcoholic hepatitis. Around 8 to 20% of these group patients of steatohepatitis, they'll end up with advanced fibrosis or cirrhosis over a period of 10 to 20 years. And about 1 to 2% per year, there is a risk of development of hepatocellular carcinoma in this group of patients. So, how to manage this group of patients? Because ultimately, we have to see why we are looking on the pathophysiology of the disease. So, as we look on pathophysiology of the disease, the basic culprit is alcohol. So, when we are targeting or deciding the treatment strategies, the most important part in management of alcoholic hepatitis is abstinence and withdrawal of the culprit agents. The other treatment modalities which has been assessed and have been found effective are management in terms of nutrition, management with steroids and other drugs, which I will be talking in my subsequent slides. So before starting, when we are seeing this group of patients with alcoholic hepatitis or alcohol-related jaundice, we want to know how much care a person needs, where we need to be more aggressive in management of this group of patients. Does all patient needs same line of management in terms of just abstinence of alcohol, nutrition and other drugs? So we have to be very watchful and aggressive when we are managing these patients, especially old age group of patients. Those who have got already established acute kidney injury when they are presented to us, those who have got severe hepatitis, those who have got evidence of leukocytosis in their blood parameters, those who are consuming higher amount of alcohol on day-to-day basis, those who have got GI bleed and hepatic encephalopathy. So basically, those alcoholics who are coming to us with jaundice, where we need to be more aggressive is this group of patients. As this study has also shown that those who have got established hepatic failure or GI bleed or sepsis, these group of patients have a very high mortality. So we need to be very, very aggressive in this group of patients when we are managing the patients with severe alcoholic hepatitis. The other clinical features which suggest that patient has got severe disease is marked prolongation of prothrombin time, or their bilirubin more than 25, or they have established renal insufficiency as said earlier also. So how to assess the severity? In addition to looking the parameters, so assessment in terms of assessing the short-term mortality as well as the long-term mortality, the few clinical as well as biochemical parameters which has been studied is the prothrombin time, the bilirubin, the creatinine, age, and based on these parameters, there are numerous scores. But most of us are using DF or Madrid's discriminant Funday fraction, where this is being defined as 4.6 into prothrombin time plus bilirubin. This is prothrombin time is difference between the patient and the control. And if this score stands more than 32, so these patients have high short-term as well as long-term mortality. And where we found that this group of patients have got some DF more than 32, where use of glucocorticoid has been indicated. after excluding the contraindication to steroids. Most important, I'll say, repeat again, before landing or easily use of the cheaper drug, good drug, we have to exclude the contraindication to steroids in this group of patients. The other severity index which has been used is ABIC. Of course, this looks better. As we routine practice, we see old age patient with renal dysfunction, with high prothrombin time, but this index has been validated only in Spain. This has been not validated generalized. The other severity index parameter used was MELD. Of course, this MELD parameter was used earlier in patients who are having advanced cirrhosis and they were posted for TIPS and later on for transplant. But any patient who has got MELD score of more than 20 is being considered as severe alcoholic liver disease. And similarly, the Glasgow alcohol-related hepatitis score has also been used. So basically, these are the parameters where we have to assess the severity, and those based on the parameters on the clinical assessment, on biochemical assessment. If you are finding the DF, which is the most commonly used index, and if it is more than 32, so this indicates that we should try to manage this group of patients not only aggressively and if possible with steroids. The same slides in the different format. As I said earlier, the matrix DF more than 32, the MELD score more than 20, the Glasgow hepatic severity index more than 9. All these are the parameters to think of that these patients have got a severe form of alcoholic liver disease, but there are certain drawbacks with each of these index. In view of that, the Lilly score was developed, which see not only at the time when we are starting steroid at 5 days, if we are finding the Lilly score of more than 0.5, which means this group of patients does not going to have the treatment, and we have to modify our treatment over a period of next 5 days. So the pooled analysis of 19 trials have shown, this has been shown earlier, the same as I said, the matrix discriminant score, when the patient has a discriminant index less than 32, the probability of survival at 1 month was more than 93, which is almost less than 10% of mortality, vis-a-vis those who had the DF more than 32, the mortality rate was around 30 to 40%. So comes to what we have in management. So once we have decided that this patient has to be managed in terms of their management, abstinence is the most important because the culprit agent has to be taken care of. The various pharmacological as well as non-pharmacological methods have been used, and I say here that we should not underestimate non-pharmacological methods in management of alcoholic hepatitis, because most of the time when we as a part of team see that psychiatric assessment indicate that most of these patients become addict to that level that they can develop severe disease, assessment of their personal interview or with the help of motivational methods, cognitive behavioral therapy, it really works with this group of patients, which most of us as clinician underestimates. So I feel a role of psychiatrist together with psychologists is very, very important part of management in abstaining this group of patients, especially severe alcoholic hepatitis. The role of these two should not be underestimated. Of course, as clinician, we use naltrexone, acamprose, baclofen. All these three drugs are easily available and it do work. But the important part which I feel in terms of abstinence, the non-pharmacological method, especially help of our psychometric analysis, psychology, counseling, behavioral therapy is very, very important role playing in their management. The dose of naltrexone used in management of abstinence is 50 milligram daily, while acamprose is just like working like a GABA agonist. Baclofen is easily available and is being used in the doses of 5 to 10 milligram thrice daily. Now comes the nutrition. Of course, Dr. Singh has already narrated the management in terms of severe alcoholic liver disease when these patients are being admitted in ICU or critical care, and he has shown that a high calorie intake together with high protein intake is one of the important major factors, not only in helpful in reduction of infections, the day of hospitalization, ICU stay, everything becomes better with the help of a good nutrition. And most of the time what we see that these patients are in either grade 3 or grade 4 in hepatic encephalopathy or severe septic encephalopathy, where role of nutrition not only with the help of NG tube together with nasovaginal tube becomes very important part of management. Again, that should not be underestimated, and we should be aggressive from day one in managing the nutrition of this group of patients. The nutritional therapy, as per evidence, almost 13 randomized control trials involving approximately 1,000 patients have shown that there is decrease in bilirubin, decrease in liver enzymes, improvement in albumin, and decreased risk of encephalopathy. But overall, the final conversion to long-term survival has not been seen based on evidence. Mortality benefit has been seen. The second line comes as steroid, where we have to use steroid. As I said, once we have established this group of patient has got a severe disease based on assessment of severity, so those who have got MEL score more than 20 or those who have got DF more than 32, these are the indication. But on the day-to-day practices, what we have seen, those who have got a very high MEL score or a very high DF score, their use of steroid is not going to give us a short-term benefit also, but make them unfit for liver transplant. So use of steroid, especially in a patient who has got severe alcoholic hepatitis, but above 54, we have seen the short-term survival has also not improved. These patients most of the time land up with infection and they become unfit for transplant also. So we have to be very judicious in indication of steroids, especially when we are managing these patients with severe alcoholic hepatitis. So what are the different other contraindications other than infection? One is active infection. As I said, most of these patients have mild to moderate to severe ascites. These patients are toxic, running fever, having a very high count, which all do occur not only in severe alcoholic hepatitis, but it also occur in severe SIRS. So establishing the, or I should say excluding the active infection is very important, where just relying on peripheral blood count is not absolutely giving us a final answer. Assessment of procalcitonin in this group of patients, assessment with the help of beta-D glucuron and the different sites like urinary infection has to be excluded, ascitic fluid infection should be ruled out, chest infection should be ruled out before putting them on steroids. The other contraindication is acute kidney injury, Purgea bleed, acute pancreatitis, and patient is already in multi-organ failure. Patient has got a very high MELD, as I said earlier also. So before using steroid, take time, establish that there is no contraindication for steroid, because once we use steroid and these patients get a superadded or severe infection, worsening infection leading to multi-organ failure, we lose this patient, the one especially who can have liver transplant for long-term survival. So how does really the steroid acts? If we see the pathophysiology of the cytokines, it's just like a cytokine storm of COVID. Similarly, this has been seen that patient who has got alcoholic hepatitis is just the storm of cytokines, which is being reverses or reduced with the help of corticosteroids. And based on evidence, as I said, the first trial of steroid was used in 1971, and later on till 2018 there are guidelines which favors that in patients with severe alcoholic hepatitis we should use steroids. The first trial was done by Raymond, who's based on biopsy used a steroid, and he showed definite short-term benefit in terms of survival. But there was no evidence of benefit in long-term survival. The short-term survival means at the end of 1 month, but at the end of 1 year there was no benefit in terms of long-term survival. The systemic review, as I said earlier also, the glucocorticoid have given the benefit, and this glucocorticoid used in patients with alcoholic hepatitis, and one group of patients who has got early encephalopathy was maximally benefited. Then comes the survival benefit. As I said, this has been benefited at 28 days, but long-term survival is not there, and this is at the risk of infection, which may be bacterial infection, and about 10 to 25% of patients, they have different forms of bacterial, viral, as well as fungal infection. So, survival benefit due to steroid is because of improvement in liver failure, but the long-term lack of survival because we already have poor liver reserve in this group of patients. So, post-steroid sepsis, as I said, and fungal infections are the major hurdle when we think of this group of patients become ineligible for liver transplant. So, should I offer steroid to everyone? I think this use of steroid should be based on benefit and the risk. And of course, those who have got very high MED or very high DF, we should subject them directly to liver transplant rather than going for this steroid therapy. The other molecules are N-acetylcysteine. This has been used together with nutrition. No benefit has been seen. The other compound which has been used in patients with this NAC has been used with prednisolone. Again, the use of NAC together with prednisolone has not given a very significant difference in outcome. Of course, this group of patients have lesser acute kidney injury in comparison to the patient who use prednisolone alone. Similarly, the other compounds have been used. The fecal microbiota, the few studies are there. And especially in patients with severe alcoholic hepatitis, one study by one of my colleagues was there, and he shown the benefit. But in our Gangharam hospital, we did not have any good experience with fecal microbiota transplant in patients with steroid, in patients with severe refractory alcoholic hepatitis. The pentoxifylline, again, it's an anti-TNF molecule, and this has also been used in patients with severe alcoholic hepatitis, and again, it was not very significant difference in terms of overall outcome in short term as well as the long term outcome of these patients. Prednisolone together with pentoxifylline has been used, and again here also there was no significant difference at 6 months survival in comparison to prednisolone alone group of patient. The anti-TNF agents like infliximab and etanercept have also been used, and both of these trials were early stopped because of very high risk of infection. So the issue comes whether we should go directly to transplant or we should think of nothing can be done for you. Now it's all because of your bad habits, you have lost. So this decision of steroid should be very, very cautiously and in a balanced way should be used as in management of alcoholic hepatitis. A very short word about liver transplant in severe alcoholic hepatitis. Earlier, because of sobriety rule, we were not able to do the transplant with at least 6 months of sobriety. But in last 5-7 years, there are good number of results from different Europe as well as an Indian setup that any patient who has got DF more than 54 with or more than 32 with failed steroid but not contraindication to transplant, or DF more than 54 or high MELD or high ARC, they should be subjected directly to liver transplant. And a good number of evidence from different European as well as US and Indian studies have shown that they behave same as of non-alcoholic patients, and the long-term as well as the short-term survival in terms of liver transplant is there. So, ladies and gentlemen, burden of alcohol-related liver disease is rising. The assessment of severity is must. Role of liver biopsy is indicated only in specific subgroup of patient. Management involves the multidisciplinary team with dietitian, psychiatrist, anonymous team, critical care hepatologist, and the transplant surgeon. Thank you.
Thanks, Dr. Munish Sachdeva, for the excellent talk. Any one or two questions only? No.
Our chairperson to kindly honor.
I interrupt, sir. First of all, thank you so much for such a lucid presentation.
I said in the beginning of your jaundice, we are the lone, but I think the management of this group vocation is multidisciplinary. We cannot understand psychological counseling is very, very important.
Providing your valuable time, sir, and sharing your knowledge with our association. I request to do honor to Dr. Satish Chagwan, our gastroenterologist, Dr. Saurabh Srivastava, sir. And Dr. Ramprata Bundela, sir. Thank you, sir. Thanks a lot.